morning. My name is Dr. Matthew Moront, and I am the Division Chief for Pediatric Surgery here at the Children's Regional Medical Center at Cooper Hospital. I'm sitting next to Dr. Douglas Katz, who is my partner, and we're here to answer your questions and talk to you a little bit about pediatric surgery at Cooper. So, Doug, I'm going to ask you a question, and please give an answer. What are some of the most common types of pediatric surgery that you and I would do here?
So, a large number of the kids that we see have appendicitis, some form of appendicitis, that we either take care of at the time, or we will, depending on whether or not it's ruptured or not, we'll deal with it over the course of a couple months. We see a lot of kids with hernias, both groin hernias and belly button or umbilical hernias. We see kids with lumps or bumps. We see kids who have feeding problems that need feeding tubes. We'll see children that have lesions inside their chest. We'll see children that have other lesions inside their abdomen. What else?
Urologic issues?
Urologic issues. We'll see children who have undescended testicles.
Hernias.
We said girls will sometimes have some ovarian issues. We, as pediatric surgeons, we will take care of a substantial amount of benign gynecologic issues in girls, most of the times who haven't had, young ladies who haven't had babies, but we are oftentimes pediatric gynecologists of sorts, even though we're not gynecologists.
We are, without sounding like we're patting ourselves on the back, the last great, thank you, the last great bastion of general surgery, pediatric surgery, because we do operate in the chest, the abdomen, the extremities, and this gives us a wide variety of opportunities to practice our craft, but it's a little different than in adults where they have general surgeons who are the breast person, the general surgeon is the thyroid person, much more specialized in children.
We both do a substantial amount of advanced, both laparoscopic and thoracoscopic minimally invasive surgeries in children of all ages, from newborns and infants up to adolescent patients as well.
So let's talk a little bit about newborns. People oftentimes think of newborns as that 7-pound child, but the children that you and I operate on are a lot smaller than that.
Right.
Could you talk a little bit about that?
Right. So we'll. One of the things we see commonly are premature babies, and we deal with some of the surgical issues related to prematurity. Vascular access. A lot of the tiny little babies will have problems getting intravenous lines in. We will be asked to help with that. We will see conditions of the abdomen, infectious issues. We will see congenital or conditions that children are born with, both in the chest and abdomen. So we tend to see a full spectrum of newborn and especially premature infants that have related issues.
What was the last baby you operated on? How big was that baby?
600 grams. So about a pound and a...
Yeah, a little more.
A little pound and a half.
Pound and a half baby.
Don't embarrass me by having to do the math.
No, that's okay. Close enough.
Right? Yeah. Okay.
And yet we operate on children that small all the way up to 18 years of age.
Right.
So it's quite a broad spectrum for us, and it keeps it very interesting and something we both enjoy very much. You have been in practice in this region for how long?
July, it will be over 19 years in the Philadelphia area that I've been practicing exclusively with children. And I completely agree with what you said. I joke around a lot with some of our adult colleagues how they could ever want to take care of, a smelly adult, because children they're fun, they're resilient, and it's exciting because seeing children at all different ages, we change how we interact with the children and also the parents based on the age and the developmental stage of the children, which makes it a lot of fun.
What do you think is different about the way that the pediatric providers care for children in terms of a team approach? Comment a little bit about
Sure.
that.
I know that in my practice, in our practice, you and I have worked on and off together for many years, that there aren't any egos involved, and we work together as a team to do what's best for the kids. And this is not saying that the adult practitioners don't, but we're very dependent on each other for second looks, second opinions, intraoperative consults, and we also have no issue calling up the radiologists, the all the peds GI people, all the different peds subspecialists, and saying, hey, listen, I want to run something by you. And I think in the pediatric surgical population, that's more the expectation that it is the norm that we work as a team. I know that regardless of what day it is, what time of the day it is, if I have an issue, either one of us could call each other in. We could call our other colleagues in over the years if we had questions, and that's just how we do things. And again, it's not saying that the adult guys don't do it, but we do it all the time.
A little more common for us.
Yeah.
We're a smaller group, and we tend to work more as a collaborative unit and discuss things. So we have that ability because we're not dealing with 600 or 700 patients.
Right.
We're dealing with a slightly smaller number of patients at any given time.
Right.
And that allows us to be incredibly collaborative and communicate really effectively and kind of function as a unit. And I think the parents really, most parents really appreciate that we are overly communicative to each other and to make sure that we get it right and everybody's on the same page. And that's really important in pediatrics, maybe a little even more so than in adults, where the patient is the receiver of the information. We have parents, we have two different parents, and sometimes they're grandparents and things like
Right.
that. So it's very important in pediatrics that we communicate effectively with one another and the parents. It's a big part.
And I think another thing, in pediatric surgery, we will see some uncommon things uncommonly. And
Explain that, would you?
so we see appendicitis a lot, we see hernias a lot, but over the years we've taken care of a number of children who have conditions of their intestinal tract that aren't seen commonly. And while each of us have had experience taking care of these kids, it's always nice to know, hey, this is a little bit different, come here and take a look, or what do you think of this one? So we have to be prepared to deal with something that's not a standard condition. Many, if not most of the adult conditions, and again, this is not saying it doesn't happen in adults, but there's a lot of regularity, consistency, and expectation for similarity of conditions. We see things that are seen once a year, once every 2 years sometimes, and part of our training is learning how to deal with those conditions and being prepared to take care of them.
So one of the things that anybody who's watching this will realize is that Camden is right next door to Philadelphia, and Delaware is not too far away, and probably many people know that there's a children's hospital across the river and called Children's Hospital of Philadelphia that has quite a reputation, and there's one down in Delaware called A.I. DuPont Children's Hospital, and there's even one in North Philly called St. Christopher's Hospital for Children. And somebody might ask, well, if you have all those children's hospitals right around, why come to Cooper? Why have a Children's Regional Medical Center in Camden?
Right.
Comment on that.
So Dr. Moront and I know those places because he and I have worked at 2 of the 3 institutions, and I still have close contact. We both have close contact with our colleagues at those institutions, and they are wonderful institutions. But for the overwhelming majority of surgical conditions that children will present with, we can safely, reliably, and very comfortably take care of the overwhelming majority of those conditions here in Camden.
So 50%, 85%?
Probably closer to 90% of what we see, I would say, we can take care of with the same instrumentation, with the same techniques, with the same outcomes, that we don't need children to go to a freestanding children's hospital. But if they need to, we'll be the first ones to say that they'd be better suited at one of those hospitals, and we routinely will refer kids out to those institutions if we think they need it. But for the overwhelming majority of conditions that we take care of, children do not need to go to one of the other institutions.
So let me get this straight. If you live in, say, South Jersey, are you telling me that you don't really need to go across the river to have your child's appendix done or his hernia done? There's no real advantage to going to a CHOP or a St. Chris or a DuPont? Is that what you're saying?
No, not from my perspective. And I left, I worked at, again, 2 of the places, and I had great experiences there. I still am involved with my colleagues at down at DuPont. No, I think that you and I can do
All those
the
things.
bulk of what those guys are doing too, and have expected the same kind of outcomes.
And I think another thing that I would echo is that there are definite advantages to going to a big children's hospital, specifically when you have a very unusual disease state, or you need an incredibly intensive amount of care. a child on ECMO, a child that needs heart-lung bypass, those types of things.
Transplantation.
The bone marrow transplants.
Right.
Those are the things where the advantage would be there. But for the overwhelming majority of things, we don't need all that kind of power. We have it right here. And the advantage is you're not dealing with 40 or 50 children on a service for the medical doctors to manage. You're dealing with a smaller number, and therefore we can give more time to your particular child, which I think is really important, especially for the average everyday thing where the needs are not as intensive. And I think that's an important point for people, because going across the river, trying to find parking, things like that, being hours away or even 45 minutes away can make a difference about how easy it is for you and the family to support your young one when they're in the hospital.
Right.
So I think that's an important point.
Yeah, and we have a pediatric emergency room. We have a pediatric intensive care unit. We have a neonatal intensive care unit. We have pediatric radiologists. We have the full staff of people for us to be able to do the things that we take care of. And again, if it's something we can't do, then on the uncommon occasions, we will have them seen by one of our colleagues in one of the other areas. And the nice thing is, if they do ever, on the uncommon occasions that they do go to one of the other institutions, they come back to us and we continue their care, and we have good communication with the other teams if they leave. The parents don't have to feel if we send them away that we're abandoning their children. We will still be, in many, if not most of the cases, deeply involved in the care of their children.
Yes, and we have great relationships with the folks, specifically the folks at Nemours and some of the people at St. Christopher's, and that allows us to extend our abilities a little bit, because they're a phone call away. Some of them even have privileges here that allows us to extend our reach a little bit, whether it's in GI or liver surgery or anorectal surgery, anything like that. We have the ability to care for those children here, and that's really important to families, so they can stay local in their community. We find that many of the fears that parents have are being so far from their children when they're sick.
Right.
And that's an important part. One of the questions that came up was about level 1 versus level 2 pediatric trauma centers. We are here at Cooper Children's Regional Medical Center, a pediatric level 2 center, and people oftentimes ask, what's the difference between a level 1 and a level 2? So I will take that one because I'm a trauma person. The main difference is in research and education. The American College of Surgeons is the kind of governing body for trauma centers, and we have all of the kind of the clinical things that we would need to be a level 1. It's just the education and research, and even there we're not that far off. It's a discussion that goes on, but as far as pediatric trauma care in this region, Cooper is certainly the leader in the whole South Jersey region in terms of pediatric trauma care, and it is certainly a leader in adult trauma care. So those two systems, those trauma care systems, work well together. They complement each other, and that allows us to deliver wonderful care to the children. So if your child is injured, this is the place in the region to go. And again, you don't need to go to CHOP or St. Chris across the river or DuPont in Delaware. You can get that care here, and sometimes when seconds and minutes count to definitive care, it's good to know that Cooper is close to you in the South Jersey region.
Yeah, historically it's funny because I live on the other side of the river, and when I first got into town, I thought that Cooper was just a trauma center, and it's not. I mean, this is an extraordinary institution that does full service adult care, oncologic care, high-end surgery of all types, and the pediatric trauma care is exceptional here. It's really a very full service when it comes to the care of children. Okay.
Other questions that we feel like need to be asked?
There's one. If anybody, I don't know if anybody has any questions online, but one of the questions that came up is in regards to the child's having surgery. How do you manage the fears and anxieties of your child? And I think it's a good question, but it's very much dependent on the age and the development of the child. One of the things that's important is, and I agree with the concept of always being honest with your child. We don't want people to tell the child that they're going to get a purple unicorn when in fact they're coming to get surgery, because then they'll never like purple unicorns, but they're also from a trust issue and understanding what's going on. I always, not just with my patients, but my own kids, stress the importance of, explaining things, but asking your children, what are their questions, how do they feel, what are they worried about? Sometimes it's not even the surgery. Depending on the age of the child, they're worried about not surviving. They're worried about being separated from their parents. They're worried about being alone. So finding out specifically what the fears are is helpful. And one of the things that's often asked is about bringing comfort items. I think comfort items are great. I just found out that my 20-year-old still has a drawer full of all his whoobies, or whatever he calls his loveys. I'm sorry.
Blankets.
I'm sorry if he's watching this right now. I'm sure you're not. But bringing a comfort item to the hospital with the child is really critically important. And we don't take them, I promise. No matter how cute it might look, it'll go home with your child.
As a matter of fact, we tend to give children comfort items when they come. So if you brought your child here for a hernia operation, chances are good that before he went into the operating room, he would have a little, some kind of a toy to hold on to. That's just one of the things that makes children's hospitals special.
Right.
I think the other thing that I would comment on in terms of alleviating the anxieties is the message to the parents is, remember, the children will oftentimes look at you. They will feel your anxiety or comfort. Right. So as you interact, if you are very nervous, very anxious, they
can see it.
They feed off of that.
Yeah.
And on the other hand, if you are calm and reassuring, the children tend to be calm and reassured. So when you are preparing for surgery, it's important that you can find a way to try to be comfortable with it. And if that means asking lots of questions or talking with the physicians or the nurses beforehand to make sure that all your questions are answered, that's really, really important. But the other thing I would remind you is that the whole staff that work with the children are very comfortable with children and families, and so I think you'll be surprised how at ease they make you, from the lady who signs you in at the desk,
right,
to the nurses that take care of you in the pre-op holding, to the anesthesiologists and the
the anesthetists who are with the children. Yeah,
most are parents.
Right, and they're focused on kids. I agree. I totally agree.
So we find that people having that worry, it's a pretty rare situation where we cannot somehow bond with the child and comfort the children and make it a good experience for them. So it's a reasonable fear, but we're pretty good at making children comfortable with their environment.
And I think that's important too, to comment that it's a reasonable fear. One of the things that can be tough, especially for the parent of an adolescent, is the expectation that they're an adolescent and they should toughen up. And these kids are still children, and they are, even 14, 15, 16, 17-year-olds can still be afraid and anxious, and they're reminding them that it's not only okay, but it's normal to be fearful and not be impatient with children. And it's very easy to say, just come on, get over this, or grow up, and it's a scary thing for a lot of kids. And the other thing I stress to parents is, when a parent receives the information that the child's about to have surgery, whether it's a mom or dad, their understanding and memory of what happens goes down by about 30%. And I tell parents all the time, you're going to have other questions. Even if you ask me the same question 13 different times and you want to meet again, that's okay. We provide availability to each other, that if a parent wants to call again and talk, we'll reach out to them usually within 24 hours to talk to them about their questions. If the other parent wants to meet, if we've only met one parent, we'll meet with the other parent again. But parents shouldn't feel that they had their window of opportunity and their time's up and they can't ask any more questions, because we don't do it that way. We will always make ourselves available before and after surgery if families have questions.
Let's talk a little bit about the other associated people who work with us, for instance, in the emergency department, because I'm quite proud of what a great job our emergency department does, and our child life people in supporting the children.
Right.
One of the things about our emergency department is their willingness, and again, this is a little different in children, our willingness to use conscious sedation to do procedures. In an adult, if you had, say, an abscess, they might just say, okay, hold on, we're going to just nip this. But in children, we don't do that. We give them sedatives and amnestics, which make them not remember and not feel the pain, and we kind of put them in a kind of a dream state for a couple of minutes while we do the procedure, so they're not so frightened. And that's really important, and that is one of the characteristics of a children's hospital. We use Child Life very, very strongly.
Child Life is great.
And that's a distracting and a comfort tool, and they help use those techniques, and they're very well trained in these techniques. We often put IVs in when the children are asleep. So
depending on the age of the child, absolutely.
Yeah. So they don't feel anything, and does it take longer? Yes. Is it more difficult? Yes. But that's how committed we are to ensuring your child has as comfortable a procedure as possible. And this is what you get when you're at a children's hospital.
Right.
Some of these things are a little different in adults, and I think it's important for people to know that a lot of effort is made and has been made to make this experience as painless and as not scary as possible. And it's important that people know that.
I think one of the things that people have talked about and parents have asked over the years, we are a teaching hospital with a wonderful residency program, both pediatrics and surgery. And we have residents and students involved with us on a daily basis, both in the preoperative, postoperative, and operative stages. And parents will see the resident and they'll say, what will you be doing the surgery? And I stress to all the parents that we, I'm not going to speak for other people, Dr. Moront and I are very heavily involved. We don't, sign your child up and then let somebody else do the operation.
Yeah,
we are there.
Beginning,
we
middle,
are there
and
from
end.
beginning, middle, and end. And that is how we do it, and that's what pediatric surgeons do. And that's what you should expect for the care of your child, regardless of where you go, with pediatric surgical care.
Yeah, people ask that question a lot, and what I explain to them is, look, I only have two hands. I can't do it alone. I need helpers. They help with parts of the case, but I'm always in charge and I'm always responsible, and they help me do things so I can do a better job.
Right.
But as far as the parent goes, the buck stops with me at beginning, middle, and end, and I think it's important for people to know that. Okay, so we've covered a lot of things here, and we would be more than happy to take questions or write in anything that you have questions to. And
we appreciate you spending time with us. We're available. We look forward. We hope you never have to see your child. We hope they're always healthy. But if there are issues, we're around, and we look forward to helping take care of your kids.
Thanks for watching.
Thanks for watching.